have something to say. Welcome, Aliyu, Miriam from Wamba, Stephen Onigbede from Ilorin, you're welcome. Let's keep it coming. Let's know where you're coming from, where you're joining us from, sorry. You're welcome, you're welcome. Oh, thank you, Tamari. Thank you. Okay, Mary, Ada, and Udward Victor, I'm not sure you have any question, but you can lower your hands. I don't think there's any, or you have something to say. Maybe you want to tell us something. Would you rather introduce yourselves? Okay, so welcome everyone. Today, you're welcome to our webinar. My name is Divine Akpan. I'm a public health professional, and I also work with Equitable Health Access Initiative, EHAI for short. We are a non-governmental organization working in the implementation of innovative public health projects, as well as research and training. And I'm sure you'll be learning more about us and what we do during the course of this webinar. So today's discussion, we're going to be talking about cervical cancer, the myths, the facts, prevention, and treatment. As you may know, January is the Cervical Cancer Awareness Month. And so we at EHI have organized this webinar to create more awareness about cervical cancer. And to do justice to this topic, we have a lineup of subject matter experts to do this. So we know that, just a brief about cervical cancer. I don't know how many of you have heard about it. If you have heard about cervical cancer, let me see your reaction in the chats. Yes, no, no, yes, maybe. Please keep it coming. Thank you. Thank you. Thank you. Okay, Tamara, you said you would like to tell us something. It's a question. Would you want to wait till question and answer session? All right, so a lot of people have heard about cervical cancer. Thank you. Thank you for the responses in the chat. Thank you, Anastasia from Now University. Thank you, Hadiza. All right. So I need to find out if our subject matter experts are already there. So let's go on with the program. So I'll give a brief introduction of our subject matter experts who will be speaking to us on cervical cancer. And I'll start with Professor Kike Lomo Adeshino. She is a consultant obstetrician and gynecologist at the University of Ilorin and the University of Ilorin Teaching Hospital in Nigeria. She obtained her MBBS degree, that's a Bachelor of Medicine and Bachelor of Surgery degree from the University of Ilorin in 1998. She's a fellow of both the West African College of Surgeons and National Postgraduate Medical College of Nigeria, and having obtained both fellowships in 2006 and 2007, respectively. Professor Kike has experience in gynecological oncology, surgeries, and prevention. She has been involved in gynecological cancer care and awareness with foundations like LEAH, Tunde, and Friends, and amongst others. She has publications in reputable journals in obstetrics and gynecology, including cervical cancer screening and prevention, in collaboration with many experts. So, welcome, Professor Kike. I'll introduce the second speaker.
Thank you very much.
You're welcome. So let me introduce the second speaker. Dr. Akadiri Olumide is the Chief Consultant of Obstetrics and Gynecology at the University of Medical Science Teaching Hospital in Akure. He had his undergraduate training at the University of Ilorin and postgraduate training at the Obafemi Awolowo University Teaching Hospital in Ile-Ife. He's a fellow of the West African College of Surgeons and a member of the National Postgraduate Medical College. He has authored publications in several peer-reviewed journals, both locally and internationally, and has a special interest in gynae oncology. He's currently the head of clinical services at the University of Medical Science Teaching Hospital, Akure, Ondo State in Nigeria. Dr. Akadiri Olumide, you're welcome. And then our final speaker, not the least, is Dr. Timothy Akimurele. He is a public health professional with over 16 years of experience, and currently he serves as the Chief Executive Officer of Equitable Health Access Initiative. So at this point, I would like to hand over to Dr. Timothy Akimurele to give his opening remarks, talk about EHAI, and also discuss the purpose of the webinar. Dr. Timothy, over to you.
All right, thank you, Dr. Divine. Thanks for the introduction. And let me quickly welcome our panelists, delectable and very erudite Professor Kikeloma Adeshina, and of course, my very good friend, Dr. Olumide Akadiri. I want to welcome, and every other participant. We're very, very, very glad to have you here for this webinar. Now, like Dr. Divine, the moderator has said, this is Cervical Cancer Awareness Month. And for me as a person and as an organization, what I imagine most of the time, and what I think you also would imagine, is why would the most important women in our lives, our wives, our mothers, our daughters, our friends, our colleagues, why would they die, you understand, of a cancer that is totally preventable? And that's the question I ask myself all the time. Because cervical cancer is one of the cancers that the scientists have figured out practically everything about it. We know what causes it, we know how it can be prevented, we know how to diagnose it early, and we know how to treat it. So if we know all these things, it means that no woman should die of cervical cancer anywhere in the world. Again, if you look at the global statistics, about 570,000 women are infected with cervical cancer annually. That's a pretty large number. In Nigeria, about 33, the incidence rate is about 33 out of every 100,000, and about 8,000 women die from cervical cancer in Nigeria annually. You understand? Sorry, there's some background noise. All right. Sorry.
I think you're audio.
Sorry about that. No. So there was some instruction. I'm sorry about that. So, like I was saying, the incidence rate in Nigeria is about 33 out of 100,000. About 8,000 women die every month. And so the whole world has come together to say, look, we need to eliminate cervical cancer because we can eliminate cervical cancer. And how can we do it? The elimination of cervical cancer globally is standing on 3 legs. First of all, vaccination of the girl child. Every girl should get vaccinated for cervical cancer. Early detection through screening to detect the early phase, the precancerous or early cancerous phase, and finally to treat it. So based on those 3 legs, we know we can eliminate cervical cancer, and that's why we're here today. So we believe in EHI that no woman deserves to die of cervical cancer, and that is why we've organized this webinar. Like the moderator has said, we are very excellent, paneling on this discussion. And I just want to welcome all of you again. And I wish every one of us a fruitful webinar. Thank you very much, Dr. Divine. Over to you. Thank you.
Thank you, Dr. Timothy. Thank you so much. Okay. Professor Kike, are you ready? Professor Kike, are you there? Hello, ma.
Sorry,
okay.
I had a disconnection.
Okay, you're welcome.
I'm sorry. Back. Yeah, I tried connecting, but the last thing I had, thank you, good evening, everyone. The last thing I had was on the incidence of cervical cancer in Nigeria. That was where I was disconnected. I'm sorry.
Okay, that's no problem.
I didn't hear anything after that. Thank you.
Dr. Timothy was just giving his welcome address, talking about cervical cancer in general. So I think we should just go on to the webinar and then start the discussion. So one of the first questions I'll ask is, can you tell us an overview of what cervical cancer is? What exactly is cervical cancer? You know, what are the signs and the symptoms regarding cervical cancer? So I'll just leave you to talk as a subject matter expert on cervical cancer. And I will give some follow-up questions as we go along. So over to you, Ma.
Okay, thank you very much. Actually, I have a little picture here, but I don't know if I'm able to share that, but I'll just go ahead because of our time. I'm told I have 5 minutes, right? I hope you can hear me. Hello?
I can hear you. The audio is fine.
Yes, we can. Okay, thank you very much. Sorry, I need that to reassure me because of what happened earlier. So I'll just give a little overview of what we're talking about. You know, when we talk about cervical cancer, some people want to know what do you mean by cervical cancer? Some people don't know what we're talking about. We're talking about the mouth or the neck of the uterus, which opens during childbirth. And that's where the cervix is. That's what we call cervix. Okay. The word is a Latin word for neck. So when we talk about the cancer of the cervix, we're now saying there's an abnormal growth, or there are abnormal cells that decide to divide uncontrollably and destroy the body tissue at that point. So we talk about abnormal cells of the cervix dividing to destroy the cervix and then spreading elsewhere. And so we talk about cervical cancer. Why is it important? It's important because it is in stages. We have the early disease, we have the late disease, and then we could talk about advanced as we go on. But importantly, when it's early, there may be no symptoms. So the patient may be asymptomatic. And along the line, when the symptoms come in form of abnormal vaginal bleeding, whether in terms of bleeding in between periods, or after sex or after menopause. There could also be abnormal vaginal discharge too, as part of the presentation or symptom. Some may present with severe pains in the pelvic area because of spread. Others may come in advanced cases when there is involuntary loss of urine or feces through the vagina. I'm sure we have seen such things like that. And because some people have some other complications from the disease, they may present with general things like weakness, weight loss, and anemia, and swellings in the body, and like that. But just as Dr. Akim Morelli said earlier, cervical cancer is very important. It affects women, it affects the young, it affects the old. It's in fact the leading gynec cancers in our society, leading gynec cancer in our society, and probably the fourth commonest cancer in women globally. So even in developing world where we belong, we have it as a major consideration. And it's also important because it causes a lot of deaths, you know. a lot of mortalities, that's what I mean, morbidities, but it's preventable because we know that it's a disease that we know comes because a woman acquires the human papilloma virus sexually by sexual contact, especially the high risk, variants or the groups, and such that if it persists in the system without clearing, it results in what? A progression of the disease. First of all, to initially like what we call pre-cancer stage that we can screen for and remove, and then before it becomes outrightly a cancer. So this is important, and that's why it's important to talk about it, because of this disease progression. So if we look at it in this way, we know that it's something important that we may be able to do what? To prevent by looking at, can we stop the acquisition of the virus? Can we also look at what constitute risk factors in women that can stop them, that we can control for and prevent people from getting infected? For example, risky behaviors that increase the HPV infection, that's the human papilloma virus infection, include things like having multiple sexual partners, early sexual intercourse or activity, smoking, or having a condition in which the immune system is weakened by infections such as HIV. By and large, we have strategies already rolled out to eliminate this, and so that's why we are here today, so that we can know that actually it's a disease, you understand me, that starts with an infection to become a cancer, but in between we have what we call the pre-malignant condition. I hope I still have time to talk.
Yes, it's fine.
Okay, so maybe we'll stop there for now, right? Because you asked me for an overview.
So we'll still have some time during the we'll be asking you to throw more light during the question. I'll be asking you some questions to throw more light, and then you also ask the attendees to ask the questions to throw more light.
Okay.
Okay, so
okay.
Thank you.
Thank you. Sorry, I couldn't say good evening, everyone, earlier. I thought I was doing that when the disconnection went off, but because of time, I was trying to just catch up, because I know we have to manage time here. So good evening, everyone. Good evening, wonderful Dr. Akim Murele, Dr. Akpan. Am I correct?
Yes, you are.
My fine friend Akadri. Good afternoon or good evening, and everyone joining all over the world. Thank you, and thank you for inviting me to participate. Thank you.
All right. Thank you, Ma, for that brief overview. So we'll still come back to you. Let me just give Dr. Akadri.
Yeah, good evening, everyone.
Yes, I'm muted. I was talking. Okay, so yes, you're welcome, Dr. Akadri. It's nice to.
Yeah, thank you very much. Good evening, everyone.
Good evening.
Good evening, sir.
And thank you, Ehai, for good evening, Dr. Kiki and Dr. C. Now, we're going to talk about prevention of cervical cancer and the treatment. Dr. Tim has mentioned very important aspects of the prevention, and it's based on three parameters, three things. Can you hear me?
Yes, we can hear you.
I can hear you.
Okay, thank you very much. Now, it's based on three types: vaccination, screening, and early treatment. Like Dr. Professor Kiki has mentioned, human papilloma virus is at the foundation, the core of cervical cancer, and it's one preventable cancer. And so it's a surprise when we have that large number of people who are dying from cancer of the cervix. And one very important way of preventing cancer of the cervix is what we are doing now, this webinar, boosting public awareness and access to information and services. We need to make people aware of this cancer. And you'll be surprised that a lot of people are not aware of cancer of the cervix. And so this webinar and this public awareness is a major part. Vaccination, like I said, human papilloma virus is at the foundation. And so human papillomavirus vaccine, if we're able to, human papillomavirus vaccine has been associated with about 98% of cancer of the cervix. And so vaccinations that is targeted at the highly oncogenic cancer of the cervix, that is 16, 18, 31, 33, and 45, will help to also prevent cancer of the cervix. Human papillomavirus vaccine is safe and very effective, and should be given to, it should be given to all girls between the age of 9 to 14 before they become sexually active. Now, there are other ways to also prevent cancer of the cervix, and that is also by preventing human papillomavirus infection. Like Professor additional has mentioned, good sexual behavior, use of condom also help, and also avoiding smoking. Smoking allows the virus to persist in the cells, and it's the persistence that leads to those changes, the precancerous changes. Cervical cancer screening is also another way of preventing cancer of the cervix. Now, cervical screening aims to get the disease at a stage where it is amenable to 100% cure before it becomes cancer, so that at that stage it can be treated and the treatment is 100% curative. There are various ways of cervical screening. You can do the human papillomavirus test. It can be by way of cytology, the common pap smear. Also, in low-income countries like ours, visual inspection with acetic acid and glucose iodine can also be used. And that can also go for, when it's detected, this precancerous can is detected, then treatment can be offered. Treatment can also be by either thermal ablation, cryotherapy, or by cutting comb biopsy or large blue precision transformation. Generally, we use this analogy that you cut, you freeze, or you burn it in the treatment of precancerous stage. And when it becomes cancer, okay, then it is also good to detect at a early stage. When it's detected at an early stage, also the treatment is almost curative at the early stage. It becomes advanced and becomes too much to handle. And treatment when it becomes when they are progressed to cancer of the cervix can be by surgery, okay, by radiotherapy or chemotherapy. Cancer of the cervix is not particularly chemosensitive, and so the mainstay is either by surgery or by chemotherapy. I think I'm still within the 5 minutes. Okay, so these are all things that will help us in preventing and treating CSF. CSF is preventive, and it's a preventable cancer, which gives a very long warning period, about 10 to 25 years warning period, where it's saying, look, I'm waiting to be caught. Catch me at this period so that you can be treated before it becomes a full-blown cancer. So it gives a long warning sign. The treatment is readily available and also present curative. And so there's no reason, if we put the will into it, why women should be dying from cancer of the cervix. Thank you very much.
Thank you so much, Dr. Akagri. That was quite brief, and I guess this is a lot of information for us. So I'll start asking questions, hoping to get more clarity. Thanks for the overview, Professor Kike. Thank you, Dr. Akagri. And so I'll start with you, Professor Kike Lomo. In your presentation, you said that cervical cancer is caused by human papillomavirus. Can you tell us more about this virus? Professor Kike, I hope she's still there.
Yes, I am. I'm here. Okay, thank you. The human papillomavirus is a sexually transmitted virus, and it has been shown to get inculcated into the cervix and result in changes that are initially precancerous and then become before the full-blown cancer. However, it is acquired by intimate sexual contact, intimacy, sex, and they're usually sexually acquired. So it is a sexually transmitted infection, can go unnoticed, Usually with good immunity, it is cleared off and it has various types, okay? We call them various types or genotypes. We have the high risk and the low risk. I'm not sure if you've heard of, well, let me just put that there. High risk, like the 16 and 18 variants, those are the very common ones. They the low risk, like 6 and 11. Importantly, what they're saying is high risk is that the high risk one are the types, cell types responsible for the cancer, while the others may also cause genital warts, okay? That's the same. So it can affect both male and females, but when it now causes, it infects the female, the cervix, it can induce changes that will result in cervical cancer. I hope that is simple enough. So I want to just know that it is sexually acquired. It can be cleared by the body, and it can be acquired just on one contact and at others several times. Okay, and if it persists, can cause cervical cancer.
All right, thank you so much. So for those raising up their hands, please just type your questions in the chat box. We'll answer them during the Q&A session. And when we get there, probably some of your questions might be answered before then, but just type your questions. If you haven't been answered, we'll take them during that session. So Professor Kike, back to you. You said HPV is can only be transmitted to intimate sexual intercourse. So that means if I hug somebody tightly, I can get HPV infection.
Okay, that's why I said the sexual okay. Contacts. That's why I said, well, in the area of sexual genitals. Let me explain like that. Genitalia. Okay. So sometimes if you have such contact because of the mucocutaneous layer, okay, there's that risk of a transmission, and that's why it can be acquired and then it can clear off too, depending on the person's immunity.
All right, thank you, ma'am. So I think there's some myths about cervical cancer. Since you said it's sexually active, is it true? Does it now mean that somebody who is not sexually active, can be contacted through sexual intercourse? So if somebody is not sexually active, the person can get cervical cancer?
Okay. By and large, majority of cervical cancer cases have been linked to the HPV infection, okay, because of what you just explained. And so we have the HPV, like over 90% being HPV positive. Okay. I hope that is simple. That I mean that, okay, if you look at cervical cancers, you could see that if you check the cells, you will see evidence of HPV there.
Okay, so
meaning majority, so it's like a direct thing. However,
cancer has HPV infection.
However, we know that there are some HPV negative, okay, cancers, not necessarily because of a sexual contact or that, but because there are some changes in the cervix that can result in the cancer in such persons, which we may consider to a little extent as a minority. So that's why we always say that women should have, even if you think you are protected, so to say, because of some reports, that women should also have to be screened for cervical cancer because of these HPV negative kind of, if I can use that word, that may have some risk of it. So if somebody is sexually active, is a risk. Of course, anybody who's sexually active is a risk factor for cervical cancer. However, it is not a justification for not getting screened because of what I've just mentioned about that little percentage that may occur. Very minute, though, not too common, but that may also occur with that.
Okay, thank you so much, Professor Kike. So from what you're saying, even if you're not sexually active, a woman should still get screened, just because of that minute percentage you spoke about. There's a possibility that it can be caught early and treated. All right, so my next question goes to Dr. Akadiri. Are you still with us, Dr. Akadiri? So my question is this: you spoke about prevention, about screening for cervical cancer. You mentioned some types of screening. I don't know if you could explain more how this is done. People who might be interested would like to know the type of screenings that can be done and how often should this screening be done by women.
Okay. Thank you very much. I mentioned the types of screening, and I'll start with the first type, which is the HPV DNA test. Like Professor Additional has mentioned, more than 90% of cancer of the cervix is directed with human papillomavirus. So if you can detect human papillomavirus in the DNA in the woman, then we can say, okay, this woman has a high risk of developing human papillomavirus. Developing cancer of the cervix. Okay, if she's HPV negative, then it's not likely that she's going to develop that. And the HPV DNA can be done within the hospital, and even now can be also be self-tested. And so that is where the direction is in terms of screening. Now, what is also available in this environment is the cytology, and that is based on the fact that the cervix shed cells, and those cells that is shared by the cervix can be collected and examined, and there are changes in those cells, okay, that will indicate whether these cells are undergoing the changes that will lead those cancerous changes that might lead to cancer of the cervix. And those changes can be whether it is the cells, the whole length of the cells is 1/3 affected, 2/3 affected, or the whole of the cells affected. And that would determine the treatment modality. So this cytology-based screening is called the pap smear. It's very popular. People will say, I'm going for a pap smear, I'm going for a site. It's almost synonymous with screening for CSM. Okay, so that is another way of screening. Now, there's also for low-income community, because pap smear, the disadvantage of pap smear is the fact that you need histopathologists to be able to read the cells. That is not readily available in our environment. You need to go to the big hospitals to be able to get pathologists to read. And so replicating that in some communities is very, very difficult. And so that also brings to something that could be done, okay, in the communities where, if a woman, the healthcare worker is adequately trained, and also look at the cervix, see some changes in the cervix, and be able to say, okay, these changes is most likely look like a precancerous change. And that comes to the what we call the visual inspection with acetic acid or visual inspection with Lugos iodine. When the cervix is sprayed with this acetic acid, those that are precancerous undergo some changes, okay, which is noted. And those changes, when that part of the cervix is noted, that part can be treated immediately. And that's the advantage of visual inspection with acetic acid or visual inspection with Lugos iodine. So it's a see and treat. So that to get this woman to the hospital for screening is an equivalent task. And so if you say, okay, we have detected, for example, for the pap smear, you take the cytology, you go to read it, it takes another 2 weeks to come back for the result, and then you come and say, okay, yeah, you have the abnormal cell, you will go and then come back for treatment. That's a lot. And so the idea of using visual inspection in this environment so that it is sprayed, the abnormality is seen, okay, and it is treated at the same sitting before she goes home. So that also has been advocated for, particularly in the environment, and it's a low cost thing. It's cheap, okay, and the materials are readily available. And so that is also one way of screening for cervical cancer. So somebody can have the human papillomavirus DNA testing, you can have the cytology, you can have the pap smear, visual inspection with acetic acid, or visual inspection with Lugos iodine. You can also, in between, also, particularly after the cytology and abnormal cytology, there's a way to look at the cervix and look at the abnormal under light with a magnification called colposcopy. To look at the cervix and say, okay, these are showing features that's suspicious for a precancerous change. Note that all this screening is to detect a precancer. It is not yet cancer. And so the person who has this, a precancerous change, does not have cancer. It is just detecting it at a early stage before it becomes a real cancer. And so, human papillomavirus DNA testing, cytology in pap smear, visual inspection with acetic acid, and visual inspection with glucose iodine are good methods for detecting or screening for cancer of the cervix. Thank you.
Thank you, Dr. Kadri. So my next question will be, how accessible are these tests? HPV tests. And it's interesting you said that the self-testing for the HPV is available. Is it available in Nigeria? Are you aware?
But it's not, even the HPV DNA testing is not readily available. Most of the places where it's available, it is based on request for it or based on certain research purposes. That's where it's readily available. WHO has advocated that this should be the standard for testing, okay, because of its high sensitivity and specificity.
Okay. And is the result of this test readily available? I think, is it a same day result?
For the HPV?
Yes.
Or for the other ones?
I think get the result the same day, and you know, if
for the HPV,
if there's need
get
to
the
commence
result
treatment as soon as possible, is it possible?
Yes, for the HPV. For the cytology, the result does not come out immediately. Okay? Once the treatment is taken, it is taken to the pathologist. It might take up to 2 weeks before the result comes out. For the VIA, the result is there immediately. So
that's the visual inspection.
That's the visual inspection with acetic acid. The result is there immediately and can be also be treated immediately.
All right. And you keep saying, you kept saying that this visual inspection is best for low resource. Okay, so that means it's easily accessible to everybody. Where can they get? Where can anyone get this testing?
Thank you very much. It should be available in every center.
Okay.
Acetic acid is not expensive. Okay, but however, the health worker needs to be trained and retrained and continuously trained on how to identify this, because we end up seeing all services as white and over-treated. That's what will ensure if that will occur if care is not taken. Okay, so with good training and retraining, it is possible for the VIA, the result of the VIA, to rival the cytology-based screening.
All right. Thank you so much. All right. So I know we are ahead of time for Q&A, but so many questions are coming in, and I think it would just be nice to take them at this time. Okay. Let me see the first question. Okay, someone is asking, can virgins get cervical cancer? Okay, maybe she meant human papilloma. So virgins can get it. Do you mean human papilloma virus? Can virgins get human papilloma virus? Professor Kike, do you want to answer that? Hello, Ma, are you still there?
Sorry, I muted myself. Okay, that's interesting because I guess it explained how it can result in, well, we can have CS cervix without the HPV infection. But I talked about, when I was mentioning the other time, I mentioned something about intimate contact in the genitals and what have you. So it depends, for some person, it depends on their other forms of sexual practices. Okay, so that way there may be that risk with that. Maybe if people that practice some more genital and all that. Okay, so it's been said that possibly, that may be a reason, but then you would wonder, other sexual practices, what we say in quotes, a virgin. Okay, I hope you meant that the hymen intact, right? So that's the definition of your virginity you're talking about. But if you go by our definition, the intimacy, the contact, I would go by strict word of virgin. shouldn't be HPV infected, except there are such intimate contacts with other areas. Okay, I hope that's clear.
Thank you, ma'am. I hope that answers your question, Rachel. Okay, so Sam Akim Boys is saying, compared, sorry, I'm sure I didn't pronounce this name very well, please forgive me. Compared to HIV, which can be contracted through contact with infected blood, like sharing infected sharp objects, hence it is not obligated. Can HPV be gotten through this procedure, that's through infected blood or sharing infected sharp objects? Can one get HPV through that, through infected
I hope we
blood?
have we've said it strictly, it's a sexually transmitted infection, but the good thing about it is that it gets cleared off with good immunity. Okay, that's one thing I should also mention, because you have mentioned something about HIV now. For
Yeah.
persons that have HIV with any form of immunosuppression or compromise, there may be the higher risk of a persistent HPV infection. May not be cleared off just like the regular person without the infection, with good immune system or immunity. So it means that HIV persons living with HIV may really have a higher risk of a persistent infection that may result in cervical cancer. That's why it's higher among them. Yes.
Thank you, Professor Kike. I think you just answered the next question. Somebody was asking, can healthy immune system eliminate the HPV virus? And you just answered that. Okay, so the next question or set of questions, the first is, how successful has HPV vaccination campaigns been? And what challenges remain in increasing vaccination rates in Nigeria? I think this question can go to you, Prof, or Dr. Kadri, whoever wants to answer. Would you want to take a question, Professor?
Well, consistently now, I know, of course, I know you will have more contributions on that. But
Okay.
generally, the uptake of HPV is low. HPV vaccination,
okay.
Yes. You know, for one obvious reason initially, availability and costs. That's one thing. So for us now, I'm sure we will start having new, and we'll start having new figures and statistics on our own response to the immunization or vaccination soon, because it was just introduced into the immunization program of national immunization program recently. That was last year. Earlier, people only had access to the vaccine on private notes, and expensive. So, and we know that, as Dr. Akadri mentioned, they're supposed to give the vaccine to persons before they do what? They have real sexual activity. That's why I want to give it to younger girls. Okay. So for now, since we have just rolled that in, I'm not sure, you may have statistics now, but I know even as of which year was that 2018, 2019, we have less than 10%, even awareness, not to now talk of the uptake of the vaccine because of non-availability. So I guess we have more indices soon on how good or what has been our response. But if we look at other climes, from studies in Norway, East Africa, and some other developed worlds, we know that there has been a significant, of course, when you compare the HPV rates amongst girls later that had the immunization earlier, and you now check them later, many years after, you could see the difference, the considerable difference in those. Let me see if I have the figures here. So what am I trying to say? That is obviously that we have a good response with HPV vaccination and reduction of the infection. Dr. Akadri, may you want to say something?
Yeah. Thank you very much, Prof. I think the low uptake is because of it's a new vaccine. Even polio, when it was introduced in the country, also had, there are issues also with uptake of polio vaccine. And so I'm not surprised at the low uptake, but I think with increased awareness, health education, and all that, there will be more uptake of the vaccine. The rate is actually very, very low. And like Prof has mentioned earlier, before it was difficult to get the vaccine for even people who wanted the vaccine, who wanted to get it. It was more than 100,000. There was a time it was even available. I think around the COVID time, it was not even available at all in the country. And so, but now it's coming back. It's also part of the national immunization and all that. And so gradually the uptake will increase. And it's been shown in areas where it's well established, it's been shown to have effect in reduction of these pre-cancerous stages of cervix and ultimately cancer of the cervix. So it's something to look forward to, okay, when the uptake starts to increase. And we'll get there shortly. Thank you.
Thank you, Dr. Al-Kadri. Thank you, Professor Kike, for giving us insight. And another question just came to my mind. Professor Kike, you said it's usually best given to, this vaccine is, the HPV vaccine is usually best given to girls before they become sexually active. So if a woman is sexually active, and wants the vaccine, would it make any difference?
Thank you. Just as we said earlier, there are various variants or genotypes, and so usually recommended that if you think you are really at risk and the vaccine is available, why not? If it's available and it's affordable. However, from public health perspective, and then because we're looking at some other factors, coverage, herd immunity, and all that, to actually give it to younger girls. Okay. However, if a woman wants it and she's older, she's sexually active, and she thinks she has at risk, why not? It's not true that because you are older, you should not have it. You'll be surprised that some people are still HPV negative, okay, or they have a good clearance and they think they have risk of getting exposed to others. So it's not completely true that once you are older, you are not a young girl, you cannot have a vaccine.
Thank you so much, Professor Kike, for throwing more light on that. And yes, it makes sense to, from the public health perspective and to increase herd immunity, to give it to, especially when these ones are free, right? Since it's part of the national immunization program by the government, and this new rollout, is targeting the younger girls who, before they become sexually active, and to create herd immunity. Sorry for our non-medical people, herd immunity means that when you vaccinate more people within the population, these ones will try to protect every other person that doesn't get vaccinated. I hope I've answered that. Okay, so another question, I think I'll direct this to Dr. Akadiri. How accessible are screening and detection services available for women in Nigeria? Dr. Akadiri, please.
That's another issue. Screening services in the big cities, I know that screening services are available, but then seriously, these are not available in the rural areas. That's the truth. And that's also the essay. In the 2010, the World Assembly made cervical cancer a public health issue and declared that, look, we need to do something about cervical cancer. Okay, we need to reduce the incidence of cervical cancer. And it was part of, Dr. C mentioned that the incidence rates in this country is about 300 per 100,000 women. And the WHO said, look, we need to reduce this to at least 4 by 100,000. And that's also where the government comes in, both at the states and local governments, to be able to set up screening centers in the wards. Every ward should have a screening center. If we want to take screening for cervical cancer, reducing the incidence of cervical cancer serious, every ward should have a screening center. At least VIA should be available at every ward. It is not too much. Okay, but right now, it's only in the big cities that you have well-organized cervical cancer screening. And that is not good at all. But we need to go to the grassroots. Thank you.
Okay, thank you, Dr. Kadri. So the last question from Anastasia is, can HPV be transferred from a mother to child like HIV/AIDS? Would you like to take that, Professor Ike?
I think it's just important to just reiterate that we're talking about something that is sexually acquired, of course, most times, and that is the usual route. Okay, of course, we know that some other viruses may be contacted, while the child is being, or the baby is being delivered through the genitals, but then notwithstanding, in this interim, so that it won't appear as though we're talking about a virus that can be acquired when you are giving birth to, and then you develop the cervical cancer. No, it's not in that through that route. Okay, thank you.
All right, thank you for the clarification. Okay, so question from Oluwashola Oni. He says, can the same variant of HPV that causes the cancer of the cervix cause genital warts?
Okay. I think I also mentioned earlier that we group them as high risk, as low risk. And when we talk of high risk, very common to the 16 and 18. However, there are the low risk that maybe like 16, 11. That is also important because they cause, genital warts. Okay, and that's what I was trying to talk about with the other transfer of excuse me, of the virus. So it's the low risk can cause genital, the low risk types, these can cause this infection and cause warts. Interestingly, they do not progress to cervical cancer, even though they look very, they look very, very, terrifying if you look at how they are seen in the genitals, but they are actually the low risk type, the 6 and 11. Okay, so they are still HPV.
Okay, but they're low risk and don't lead to cancer. Thank you very much. Okay, someone is asking, I think it has been answered a bit. Maybe needs more clarification. Is testing free? Dr. Kadri, I think he talked about HIV, sorry, the HPV DNA, the pap smear. I guess those ones are available in the bigger cities. Well, how much does it cost? Maybe if you could let us know. Is there any free test? Let's even start. Is there any free test?
Well, except for probably the VIE, and that's when it's government sponsored. There are no free tests. Okay, there are no free tests, and the cost it depends on from one locality to the other. But then, the question is, what is the cost of managing cancer of the cervix? Because that's what you weigh against each other. The cost of managing cancer of the cervix is enormous. The cost of radiotherapy, how many centers in this country have radiotherapy machine that is working? There are very few. Probably Lagos, Abuja, maybe so in Kaduna. So maybe 3, 4, 5 centers in the whole country that can, and the cost is enormous. So if you just suppose that with whatever the cost of screening for cervical cancer is negligible, is nothing at all. So everybody should make, every woman should endeavor to screen. Yeah, there was a question you asked, and the other time, and I think along the line, I skipped. And that's when the frequency of screening. And it's estimated that every woman should start screening at about the age of 30, and to screen every 5 to 10 years, starting from the age of 30, except for people who are living with HIV, where they should start screening at 25 years, and that should be done every 3 years. Okay? So if you do that in a lifetime, you probably be screened maybe 2-3 times with that. And I think that's whatever the cost is, that's okay. That's good enough. Because when I see people with CSMs, I feel like crying. Okay? Because the pain, the wahala, the stress of the diagnosis, and you have to move to Lagos, you have to be on the queue. Okay, you have, before you can get your radiotherapy, the side effect of radiotherapy itself, and all that. And for something that is preventable. So I think the cost is negligible to compare to what you are trying to save your own cell phone. Thank you.
Thank you, Dr. Kadri. So I think the message is that screening is far cheaper than treatment. So go for screening. Well, I do know there are a lot of sponsored free screenings, especially with individual inspection, either with ASEDI, and those are usually either government sponsored or by some NGOs, and some foundations do that from time to time. So if there's anyone happening around you and you're a woman, you're advised to just use the opportunity to get screened. Okay, so
Yeah,
Dr. Akadi, just
a minute.
sorry?
I did mention about the NGO sponsors, because usually it's for a timeline. Okay, usually it stays for like about a year or 2 years, and then the support is no longer there. And so that's why I didn't talk about it being free and all that. But then there are available in various states of the federation.
All right. Thank you, Dr. Kadri. Sorry, Dr. Kadri, please, I just want to ask a question, because you mentioned it, that a woman should start screening from. Okay, Professor Kike, you want to say something?
Yes, I actually want to. So when he was talking about any free test, something like that, we know that there's no free lunch even in Freetown. Somebody is paying somewhere.
Okay.
But we can actually look at maybe as we go on in our policies and what have you, to look at how we can incorporate that into the our health insurance. I'm not sure it's really part of it yet, and it's something that can be done, and it's cheaper all the way, where you have to do, you have to screen a lot more persons than just that. Even that way, it will make even the HPV testing also available, and we can even have more information and get more data on that in our own environment. So I think what we should also try and pursue, as we all talk along, because I don't know if we have some policy makers or influencers here, to look at how we can see how we go through that as a route for women to get it screening as part of something you can just get under your health insurance. Thank you.
Thank you for that. I think it's really important to note that people to put it as part of health insurance, that's screening for HPV or cervical cancer, whichever one, we can include it in our insurance. So let's just quickly go through some other questions. Okay, doctor, I think some questions have been answered. Is it safe to get HPV vaccine after undergoing treatment for precancerous cells? Faith Aldo is asking. Somebody who has treated precancerous cells, maybe from a visual inspection, had one of those thermal ablations that Dr. Kadri mentioned. Is it safe to still get the HPV vaccine after that procedure?
What it means is that the HPV has already done its damage. That means the person is already infected. Okay? And the damage on the cervix has already been done. So the taking the vaccine will probably have no effect on that. You understand?
Okay. All right. Thank you. Okay. The next question is, does cervical cancer have implications on pregnancy? Prof, would you like to answer that?
Cervical cancers will generally influence pregnancy, no matter what. What we need to just look at now is at what stage of pregnancy or what gestational age and what stage of the cancer. So invariably, it's important because we actually pick some people in pregnancy. And so you are now left with, okay, how do we, balance out? So in a way, you could have effects of that on the outcome of pregnancy, may determine, the well-being of the mother, the fetus, how you want to deliver, and the possible outcomes, okay, for such women. So it's important that we do that. In fact, because of the targets, and sometimes why it's difficult to get people to get screened, they actually may come in. You may get some people, you may have to screen some people during pregnancy because they don't come around. Okay. So in a way, you may say the pregnancy offers sort of opportunity to screen women, to look at the cervix and to even have some more information. But by and large, that's the effect. Now, the other thing is that pregnancy will definitely influence the type of treatment you want to give a cervical cancer patient, definitely, because depending on the stage, if it's something you think you can do and deliver and then take care of the surgery, or you do that and send for radiotherapy, chemo, and all that. So that's the mix, the effect of pregnancy, and these are the effect of the cancer on the pregnancy. I hope it's clear.
Yes. I hope it's clear to Musahai Demudia. Okay, sorry, no, that's not the first question. Yeah, it's Udwak Victor who asked that question. So as far as Esther is asking, how often should, I think that has been answered, a woman should undergo cervical cancer screening every 5 years. I think Dr. Kadri has answered that. Then Nosa is asking, does birth control impact the risk of cervical cancer? Nosa, I don't know. Nosa, are you there? Maybe you should explain your question. Is the particular birth control method you're talking about, or general? Nosa, if you're available, you can unmute and ask your question. Okay, I don't know if Nosa is still there, but Professor Kike or Dr. Kadri, would you like to say something to that question? Does birth control impact the risk of cervical cancer?
What we would like to say is that, okay, from the literature, we have some works that have shown that long-term use of some estrogen-based pills may actually impact on the changes that may result in cervical cancer. And that's maybe the effect of estrogen on the cervix, probably because of the person that has been exposed to the HPV before. And it was shown that maybe after, if it's not a long-term use, they get what? They get it's they are not at risk. However, from what we mentioned earlier, it told us that it's intimate relationship, usually, sexual activity, okay? Frequent sexual activity, so that may increase the risk of having HPV and then CS cervix later. So it means that if there are protective to a way, you can use barrier methods. They may actually protect against the HPV, and then of course reducing sexual activity. So that's one way how birth control influences the outcome for HPV infection. And the other way is what we mentioned from statistics and observation with oral combined pills over time, causing those changes in the cervix. I don't know, Olumide, Dr. Kadri, if he has other things to say.
Yeah, thank you. Like Prof said, condom, barrier method of contraceptive, prevents human papillomavirus infection, and so it prevents helps in preventing cancer of the cervix, particularly female condom helps in preventing cancer of the cervix. Studies have shown that combined oral contraceptives provides probably the environment makes it a bit more conducive for human papillomavirus changes in the cervix, and so more susceptible. But then it's also been shown that once they stop using it, the risk also reduces back to normal. And so by 5 years after it has stopped, the risk is not different from those who have never used the combined oral contraceptive. Thank you.
Okay, thank you, Professor Kike. Thank you, Dr. Kadri. Let's go to the next question. This is from Stephen Onikbede. He says, I know HPV vaccines for women. Are there any for men? If not, why? And if there is any development for its availability for men? Dr. Kadri, would you like to answer that?
The HPV vaccine is actually not gender specific. In some countries, it's actually both for boys and for girls. Okay, I think we are starting with girls now because we don't have enough money to vaccinate everybody. So let us just take the girls first, and after that we can increase the uptake to involve also boys. But along the line, I think ultimately that's what we'll get that to involve both boys and girls. So it's not gender specific. It's both for boys and for girls.
Thank you so much, Dr. Kadri. Okay, let's quickly go to the next question from Tamari, our Zambia participant. Between which ages is cervical cancer active? Professor Kike or Dr. Kadri, do you want to answer that? Between which ages is cervical cancer active? From Tamari.
So I want to assume activity in terms of, okay, when it's more prevalent in the reproductive age. Did I get that question where it said active, right?
Okay, Tamari, are you there? On mute and maybe
cervical cancer active, right?
Tamari,
I want to assume you mean maybe
Yes.
when
Yes.
women.
Yes, I'm there. I'm trying to find out when does it affect the age? Which age group is more affected? Is it the younger age or the age above 45? So that we know how to handle it, because I'm handling about 1,000 girls and they are below the age of 30. So to advise them to go for screening, I would love to know which age it is active, so that as I talk to them, I'm also helping them with that knowledge that you are descending to us. Thank you.
Hello, ma. Professor Kike, did you get the question now?
Okay, so you are trying to say that, okay, that we know that prevalence of the disease from even from what Dr. Kadri mentioned, when we look at ages, older women, 45, 60, 64, no, older women, but younger women can also have it. So it's a problem of women, well, you can call it in the middle age, like that, more commonly. However, if we look at the progression of the disease, right, we are looking at screening before, because we have the infection coming in, causing the cancer. We think it may take some years for it to develop into, a disease progression to occur, right? So if we look at the progression of the disease, we may now look at when to educate women to get screened. Okay, so we are looking at a disease progression from time of infection to invasive cancer like 10, 20 years. So we need to educate that, okay, the younger, of course, women who are not vaccinated or who are sexually active from age 30 and are getting, and around that age should get screened. And so to prevent the risk of getting the cancer later, so that we can pick the pre-malignant stage that occurs like between 10 to 20 years after the initial infection. So I think if you have that information, you can educate the young women that you have in your community, the person that asks the question can educate on when to get screened and when this disease can become active in them. I hope that answers your question. That's my contribution.
Yes, please. Thank you very much.
All right, thank you so much, Ma. Ido, Michael, I see your hand is raised. We can quickly finish the questions in the chat. We'll get to you quickly. Okay, so the next question is in VIA method of screening, and if positive, then you treat with TA. Should you retest again to know if you are okay and when? From Amina Azari, I'm not sure I can make out. Are you asking if somebody does a VIA screening, is positive, and then they go for treatment, maybe with thermal ablation? Should they retest again to know if they are okay, and when should that be done? Is that your question, Amina?
Yes, that's the question.
All right. Okay, Dr. Kadri, would you like to answer that?
Yeah, thank you. Yes, if after treatment, it's recommended that you go back after a year after the treatment for a retesting. Okay, so that it can be retested again with VIA after a year of testing, after a year of testing and treatment.
All right, thank you, Dr. Kadri. Okay, so somebody just made a comment. Rachel said some HMOs have, I think that's cervical cancer screening in their, as part of their plan, once in 3 years. Elo Best is asking, are vaccines readily available? I think we've already dealt with that. Then Sefo is asking, what is the age range of women to be screened? I think Dr. Akabi has already answered that and said it's from 30 years upwards. Okay, Ido Michael, please go ahead with your question. And unmute and that's
Jimmy, they asked me whether if I have heard from you. Just the chatting. Okay, ma. Good afternoon, everyone. Yes, I just raised up my hand because of the last response. I was at the health center last week when we were having the OBRO program, OBRO 1 for 2025. And the lady walked up to the health center. She's 22 years, and then the result she came with showed that she is HPV positive. She actually did hepatitis B, she did XYZ, and she did human papilloma virus, series of tests carried out. But among all this, the human papilloma virus came out positive, and then she was now referred to the health center. So we also had to refer her to Igondo General Hospital, which we are not aware she eventually went. But I'm saying this because of the age bracket for the screening and the sensitization. She's 22. I even asked her if she's sexually active and when was the last time she had sex. And she was saying it's been a while, that she just decided to go for a series of tests just to check if she's intact. So I'm looking at that age bracket for the sensitization. Can we make it a little bit, backward, probably down to 18 years and then something like that? Thank you, ma'am.
very interesting observation. Thank you, Ido Michael, for that. Dr. Kadri, do you have anything to say? Or Professor Kike?
Thank you. since she's HPV DNA positive, what it means is that, it is not that she needs to be treated, but she needs to also be observed because those changes might not be there in the cervix. Okay. After a while, she might even clear the infection. Okay, we talked about the persistence of the infection is the issue. Okay, so she might be able to clear the infection and there won't be any or any problem at all. So it is for her to go for a regular screening, but because she has had the HPV positive, it means that she has a high risk of developing the precancerous lesion and also ultimately the cancer of the cervix. And for her, if she has a precancerous lesion, we take that more serious. That's somebody who is HPV DNA negative. Well, if she's HPV DNA, and say, okay, you are good. Okay, but since she's HPV DNA positive, okay, she will go for the regular screening. And if now we see those abnormalities, then she will be treated.
All right. Thank you, Dr. Kadri. So I think his other comment was, because of this kind of scenarios, would it be advisable to lower the screening rate, or would it be just like this is an outlier? But what do you recommend? The recommendation is from 30 years you should be screening, but somebody now does that at 22 years and is HPV positive. So should the screening age be lowered from 30? Should we advocate for that?
Yeah, I know that in some clients, they will consider age, some people consider age 21, okay, because of the prevalence. And of course, just based on some observations like this. Obviously, as Dr. Kadri mentioned, this person definitely needs to be screened. And when we have that, that's why we actually need more data, to make our recommendations. There are outliers, of course, we know some will be like that, but I think it may be a consideration for in some places to have it lower down. In fact, we used to say that by the time the woman is sexually active before, you're sexually active, your sexual activity is you can calculate is 10 years or thereabout or what, you should get screened. And that's the beauty of the HPV. Okay, you can know when to do what. 3 earlier, this person needs to be earlier, or as we said earlier, if there are other comorbidities, co-infection that may increase, I think that's risk. So it's important to consider in such cases. So that's why you have for some people that are living with HIV or you have evidence. In fact, in some areas when there's evidence of chlamydia positivity, you should get more screen, okay, because of co-infection and the effects on the precancerous state.
Thank you, Professor.
We have to consider that, yes.
Thank you so much. And then there's another related question. So Sefo is asking, she's 53 years old, and she was at the center last week and requested to be screened, but the health worker said that she was above the screening age. So she's asking, what's the latest age for screening? At what age do you get to that you need to stop screening for cervical cancer? Professor, sorry, Dr. Kadri, you wouldn't answer that. Yeah.
So how old is she?
53.
Okay. Now, if a 53-year-old woman comes for screening and she has never been screened before, okay, it is good she has to be screened. If she has never been screened before, or if a 53-year-old woman who has had 2 previous negative screening comes, then you can say, okay, you probably don't need to be screened again. Okay, because if she has not acquired that human papillomavirus infection to induce those changes, then at 53, it's not likely that she's going to have that again. You understand? Okay, but if that is the first time of screening, then it should be screened. I know that most of the cancers occur in what we call the transformation zone, which postmenopausal tends to go a bit go in, and they getting that smell from that transformation zone might be might be difficult or be nearly impossible. But then, if she comes in for screening, it will be screened.
Thank you so much, Dr. Akari. So really, we can say that there's really no age limits. If your first time of screening, yes, whatever age, please go ahead and get screened. Okay. I hope that answers your question, Seifo. I think the discussion has been very interesting so far. So if you think, just send your emoji to let us know how you're feeling about the conversation, how you feel. Has it been exciting so far? Has it been interesting? And if you still have any question, please, you can put up your hand and ask, or you can type it in the chat box. We are about to round up. So I'll just let you know that this webinar was brought to you by Equitable Health Access Initiative. And like I said, we are a non-governmental organization and we implement a number of programs of public health interest in Nigeria. So I'll be pasting our links, social media links, as well as our website for you to get connected with us, to learn more about the work we do, and to follow us on our various activities. Okay, I thought I saw a hand up. Has it gone down now? Okay. All right. So, Anastasia, okay, quickly ask your question. I think that'll be the last question before we round up.
Okay. Good evening, everyone. Mine is more or less a suggestion. So, it's concerning.
I can't hear you again. Is this just from my end? Anastasia? Sorry, Anastasia, you went off a bit.
Can you
still come back?
Okay. Can you hear me?
Yes.
Okay. Mine is a suggestion. Given the changing trends and how our environment is changing, it has definitely affected many.
Can't hear you again.
People's immune.
Is it a comment you have? Maybe you can type it in the chat box so that.
Okay, no problem. I'll just type.
Okay, so I think we're almost getting to the end of the webinar. I'll just call again on our Chief Executive Officer at Equitable Health Access Initiative, Dr. Tim Akimurele, to give the closing remarks. And you can also tell us about some things we're doing regarding cervical cancer. Thank you.
All right, thank you very much, Dr. Divine, for that good moderation. Thank you. That was very good. Dr. Kadiri, Professor Kike, additional, we're very, very grateful for that. That was insightful. Even I was learning a couple of new things, statistics, cervical cancer practice very soon. All right, just to, why are we having this webinar? Like I said, we believe that no woman should have cervical cancer anywhere in the world. And we're excited to join the global community, in talking about this and also taking action to ensure that we're able to eliminate cervical cancer out of the world. And it is estimated that about over 60 million lives, 60 million women lives will be saved if we can eliminate cervical cancer globally. That's a huge number. Every country that's under United Nations umbrella, they all signed up to eliminating cervical cancer drive. So at EHAI, we have a couple of initiatives that we're aiming to help support this drive. First of all, we're a member of the Global HPV Consortium. So we're joining other partners to fight HPV and cervical cancer. And that's looking at both research, implementation, and also interventions globally, working in different countries to help eliminate cervical cancer. And then secondly, in Nigeria, coming local now, we're trying to help improve the uptake of cervical cancer vaccine, which is the primary prevention, by one of our projects is automating the childhood immunization program, which is where cervical cancer HPV vaccine is situated. So we're automating the process, making it more efficient, such that we don't miss any girl, because once you can automate a process, it means that you don't miss any girl once they are born. It means by the time they are 9 years old, the system picks them up automatically, or once they register in the facility for any, you understand, for any vaccination at any age, once they are 9, the system flags it automatically, and we ensure that they are vaccinated. So that way we can improve the HPV vaccine for girls between the age of 9 and 14, which is very critical for the elimination of cervical cancer. That's the first leg. And then the second leg of what we're doing, we'll be conducting a clinical research in the second quarter of this year. And because we've talked about screening a lot, and unfortunately, HPV, testing is still technically speaking, still the best way, because it detects the virus. The other test, pap smear, the visual inspection, that with glucose, iodine, acetic acid, they pick up lesions, so they're kind of late in terms of for public health, in public health perspective. So we're looking at what we're trying to do, and Dr. Kadri talked about self-testing. We're looking at how to introduce tampons, vaginal tampons, medical grade vaginal tampon. There's a factory, there's a company that's making vaginal tampon that is medical grade. So it makes HPV testing easy. You just take the tampon, insert it in, bring it after 5 minutes, and you can do it in your home. So we're doing a clinical test. We're running a study on that in Lagos and Nasarawa State in the next second quarter of this year, and that's supposed to help us, get a better grasp of how we can really bring HPV testing to the forefront. We're also working with National Cervical Cancer Elimination Task Force that was set up to also see how we can, because using pap smear or VIA, visual inspection, it's kind of like cake in 2025. It doesn't help anybody. We're trying to see how we can prioritize HPV screening. Like Dr. Kadri said, if you look at the cost of treating cancer, the economic cost, you understand, the cost on the family and the relative, you find that no amount of money is too small in terms of no matter how expensive the screening is, you can't compare it to when you come down with the cancer. So we're hoping that if testing can be made available, and the national program prioritizes it, because the national program is really interested in meeting the cervical cancer like every other country in the world. So they can prioritize HPV screening, make it the standard gold standard for screening for cervical cancer. Then we can detect earlier, and we can make sure that we address and we can eliminate diseases across the country and across the world. So that's where we are. We're putting in effort to working with global partners and also coming locally, to address cervical cancer, make sure we join the fight to eliminate diseases. So once again, I want to thank everybody. Over to you, Dr. Divine. Thank you very much. Time is fast spent. Thank you. Thank you so much. Yeah.
All right, thank you. I think we have maxed our time out by 1 more minute. So thank you so much. Thank you, everybody, for participation, for the questions. Thank you, Professor Kikelomo, and thank you, Dr. Kadri, our very able and knowledgeable speakers, subject matter experts. Yes, please give them a round of applause. Please, please, please give them your clap emojis. Thank you so much. We're really grateful. We've learned a lot. And so just to close, we are Raphael. Sorry, we have to close now. We have to end. We are maxed out. We can't take any more questions. So, but you can follow us on our social media and connect with us. You could ask your questions there, and we will definitely get back to you. Just follow the links on the chat to our social media pages and also our website. Thank you so much. Have a lovely rest of the evening. Bye.
Bye-bye. Thank you. Bye.
Goodbye.
Bye. Bye, ma'am. Goodbye, sirs.
Thank you so
Bye.
much.
Thank you very much.
Thank you. Thumbs up. Thank you, guys. Thanks, guys.
Bye.
Thank you.
Okay, thank you.
Bye. Thank you.
don't see me.
Bye bye.
This year that this year the job.
Them to they see you.
Bye bye.
Bye.
Again, don't
you.